Hello dear friends, this is Dr. Dushyant Khedikar. In today's surgical video, I am demonstrating the surgical principles of the management of obliterative otosclerosis. This is the stepidotomy surgery of right ear. The tympanomeatal flap has already been elevated and the bony posterior superior canal wall overhang has been curated out. After disarticulating the IS joint and cutting the stapedius tendon, crurotomy is done and the stapes suprastructure is removed completely to expose the oval window area and the footplate completely. Just now, you saw the removal of mucosa over the stapes footplate area. This can alternatively be done with the help of blunt instruments. Once you delineate the obliterative footplate, drilling is initiated on the footplate area in a circular fashion. The circular fashion of drilling over the footplate ensures uniform saucerization of the footplate. Uniform saucerization of the footplate minimizes the chances of accidental fracturing of the footplate. While the saucerization is done, care is taken not to apply any force over the drill. In the present circumstances, I am using a 0.6 mm diamond burr at a very low speed. After every drilling attempt, suctioning is done over the footplate area to clear the debris and bone dust accumulated over the surgical field. Dry drilling as well as prolonged drilling is strictly avoided. This will prevent the heat generated during the drilling process, thereby minimizing the thermal damage to the labyrinth and thus preventing the post-surgical iatrogenic sensorineural hearing loss. Periodic suctioning ensures the uniformity of saucerization being carried out. Copious irrigation is avoided during the attempt of drilling, as this will hamper the surgical vision. At the same time, before every drilling attempt, the burr is dipped in saline solution so that it carries just adequate amount of saline with it to prevent the dry drilling. Intermittent wash is given to clean the area. As the saucerization of the footplate is continued, you will appreciate the change of color of the footplate from a dense white color to a light blue color. This is called as blue thinning of the footplate. Here you can now appreciate the appearance of bluish hue over the footplate. saucerization is further carried out to make the footplate saucerization as uniform as possible. Once adequate saucerization is done, a bony fenestra is made at the desired site, preferably in the posterior quadrant or a posterior quadrant and the middle quadrant, depending on the location of the incus. The bony fenestra is made without damaging the endosteal layer. Here you can now notice the formation of bony fenestra. The bony fenestra is now enlarged to a desired size. Suctioning is prevented directly over the fenestra so that to avoid the iatrogenic sensorineural hearing loss in the postoperative period. Now the fenestra is widened with the help of a perforator. You can notice that no pressure is applied over the perforator while performing this step. After the adequate perforation is made in the footplate, the distance or the length of the required piston shaft is measured and the piston of adequate size is cut. Now it has been edited in this video. The piston is placed as perpendicular as possible into the fenestra and looped onto the long process of incus. It is gently maneuvered using a pick. Now gently suctioning out the accumulated blood over the footplate, the position of the shaft into the fenestra is confirmed. Once the positioning of the shaft is confirmed, next the loop of the piston is crimped gently for the long process of the incus, ensuring a snug fit between the piston and the incus long process. A snug fit is essential to prevent the play between the piston loop and the long process of incus, thereby minimizing the chances of erosion and necrosis of long process of incus. Once the piston position and crimping is confirmed, the tympanomeatal flap is repositioned for the canal wall and subjective improvement in the hearing is tested. This ends the surgical demonstration. Thank you.